Sure.
Before you start?
Yeah.
So how far after radiation are you talking about side effects? Immediately or long-term?
It's a good question. So this will be kind of taking you through the first few years afterwards.
Okay.
So in general, the reason why people have side effects from radiation is this. So anytime you're radiating tumor tissue, there's going to be a margin of normal tissue around it that's also radiated. In addition, depending on where the tumor is, the closer the tumor is to the vital structures for vision, being either the optic nerve, the cable that connects the eye to the brain, or being the center of the retina called the macula, the more the vision can suffer, just because it just means that the radiation is also hitting those critical structures for vision. So off the bat, the location of the tumor can be very important in radiation side effects to your vision. Now, with regards to the two different forms of radiation that are used in the US, there's proton beam radiotherapy, which is an external beam charged particle form of radiation, which we use at our institution, and there's a few others, or plaque. Generally, the side effects of the eye are essentially the same. So what can happen is, and this is a term that was actually coined by my colleague, Dr. D'Amato, toxic tumor syndrome. So essentially what happens is, as the tumor cells are dying, the tumor starts to leak fluid. So what you can see is the retinal layer can start to detach, and that can definitely affect vision. Now, there are a variety of treatments that can be given for that problem. There are medications we can give in the eye as injections in the office. There are several medicines that can be used. These are actually the same medicines that we use for other eye conditions like macular degeneration, which is in older patients where they can get bleeding in the eye, or in diabetic eye disease. So there's medications called Avastin, Lucentis, Eylea, and those tend to be given as eye injections monthly to help with swelling in the retina or retinal detachment from radiation damage. In addition, steroid medicines can also be given in the eye, so they can be given as injections inside of the eye or around the eye. The medicines that are used for that are called Triesence or Ozurdex. It's a little pellet of steroid. And those things can help as well. In addition, what some people will do is they'll actually treat with laser the retina. So the laser areas, if there's any bleeding, things like that. Now, another thing that we've used with some success is this. There's a type of laser called PDT, which is a light form of laser treatment. So we actually give a dye infusion through a vein in the hand, and then we shine a light at the tumor itself. And that can sometimes help curb some of the leakage from the tumor, and that can be helpful. We've done that in some patients also. So there are a variety of ways to kind of deal with the side effects. And some of that can vary, again, depending on where the tumor is inside of the eye, how big it is. In general, the larger the tumor is, the more it can leak after it's treated. And so these are all things that we've kind of come to expect. So what questions do you guys have about some of these side effects?
So I have a question, because this just happened to me. So I got flashes in my eye. I was really irritated, red. I had been exposed to some excessive amounts of particles. They were doing construction where I work. So luckily, just by chance, Dr. Harbour happened to be in Palm Beach Gardens where I live, not Miami. So they saw me, and everybody panicked and did all these tests. I mean, I felt like it was like, oh my gosh, all these tests. And then they were like, oh, you're fine. We're going to give you some drops. Your retina's not detached. But my question is, if I have that, I have to worry every time there's flashes or irritation. Like, should I be concerned every single time? Run to the doctor because it could become detached?
It's a good question. So in general, the sensation of persistent flashes in your eye is basically a signal that there's something going on with the retina for some people. So the retina is the wallpaper that lines the back wall of the eye. And if there's ever any gel, so the jelly in front of it called the vitreous, if it's ever tugging on the retina, that can cause flashes. If there's a tear in the retina, that can cause flashes. And actually, if the retina is detached, you can get the sensation of flashing going off too. Now, in patients who don't have a melanoma, the retinal detachment is most commonly caused by a mechanical problem. So what can happen is you can get a tear in the retina, fluid can get beneath the retina and detach the retinal layer. But in patients who have a melanoma, the flashes can actually just be from the fluid that's leaking from the tumor itself. Yeah. And so it can be a similar, that's just how the retina transmits that signal to your brain that something is going on. So there's fluid underneath, it'll start giving that flash that goes off. So that's the reason.
So what should be the 911 to run to the doctor? Like days of flash?
I think honestly, you know, if there's ever any question there's something new going on,
Okay.
or if you have a vision change, if the
Oh.
eye hurts, the eye gets more red, I always err on the side of caution. So if somebody calls a symptom, I always see them right away, and then we can
Okay.
pretty much tell you if it's something to be concerned about or not. But in general, anything that's like a change, so new flashes, new floaters in your vision, any kind of decrease in vision at all, if the eye hurts at all, if the eye gets red, those are things to let your doctor know right away.
So maybe that's why they were so, I mean, it was a whole combination of things. It wasn't just the flashes.
Yeah, it sounds like they manage it exactly. You know, that's the way to do it. Be very conservative, check everything out, and go from there. So, yes.
Can you speak to the effectiveness of the PET treatments?
PDT. Okay, so that can be helpful for tumors that are on the smaller side. So that form of laser, initially people were actually trying to use it to treat melanomas. The problem is it's not as effective at killing the melanoma, but it can actually help shut it down so it doesn't leak as much. But the thickness cut off for that to be effective tends to be around 3 millimeters or so. So that's part of the principle, though, is you know, some people give injections very frequently to try and curb the fluid and swelling, but what we now kind of know is that you want to actually treat the underlying cause. So if the cause is the tumor that's dying, and if you actually treat that with laser, that can actually help shut down the fluid more than just injecting every month.
Could it actually reduce the time in between Avastin injections, or could it?
Potentially, yes. So I've actually done that for a couple of patients who've not needed injections again, actually. But these, to be fair, these were thinner tumors to begin with. But the laser can be effective. Now there are a couple of different forms of laser. There's a laser that's applied that is actually, you know, it activates with heat, and that causes kind of damage. And that's the kind of laser we use for diabetes and other problems. This PDT is actually a light-activated source of cold laser, so it's a little bit of a different mechanism. So the effects to vision tend to be much less.
Curious,
Questions?
so my tumor was near the optic nerve, and so basically my optic nerve is, you know, swollen, which they treated with Avastin. And it looks less swollen, but it's like white, and we basically don't have any other options.
Yeah, it's tough. So, you know, the cable between the eye and the brain, the optic nerve, once that suffers damage, unfortunately the effects can be irreversible. But I'll tell you what I tell all my patients who have tumors that are involving the fovea or the optic nerve. It's really a blessing in disguise. You're the patients who come to detection sooner because you have symptoms sooner. So it's, unfortunately, there's no magic bullet for once, you know, the optic nerve starts to suffer from radiation. But that being said, hopefully it also brought you to detection sooner and were treated earlier, and so that's positive too, I suppose. Now, some of the effects from radiation, what we typically tend to tell patients is that it can take a couple of years to show some of the effects, actually. So optic nerve damage, for example, can take a couple of years. We do have some patients who get swelling in the retina 2-3 years later. There are patients who have bleeding and things that need surgery to vacuum out the bleeding or laser, things like that. And some of those effects can actually be seen 2-3 years later.
Go ahead.
Oh, I have two questions, actually. One is in relation to how many years. I had the brachytherapy 5 years ago, and I still don't need Avastin. My vision's good, nothing's bad. I did have a cataract removed.
Got it.
This year. So, am I in the clear, or?
That's great. I mean, I would certainly hope so.
Wow. Okay,
Right,
lucky. Question number two, is it possible that the brachytherapy caused memory problems for me? Because it sure seems like it. I have that question.
It's a good question, not that I'm aware of.
I mean, it could just be old age, and it was coincidence that it happened immediately after the brachytherapy, but it sure seemed related to me.
I'm not aware from radiotherapy, and I will say this. I mean, because I do plaques as well. We do more proton beam where I work, but we do plaques as well. And we have a physicist in the room who's measuring, and you know, there's a lot of,
Insurance very careful.
yeah, I mean, for radiation to actually be able to travel out and affect the brain, I would be very surprised. Now, there are different forms of chemotherapy, which is not a treatment for this problem, but if anybody here has any family member or has seen someone go through chemotherapy, that has actually been shown to cause, in some patients, memory problems, but not radiation as far as I know.
So
Not
I
this
had
kind of radiation.
chemotherapy in 1997. That wouldn't suddenly cause memory problems. 20
I wouldn't
years
expect it
later,
to be
would
sudden, but if you've ever known somebody who's gone through systemic chemotherapy through a port where it goes all
Yeah,
over
that's
the
what I
body,
did, yeah.
they can actually get what's called chemo brain, where they can be kind of forgetful for a bit and
I
have
was
other
fine
symptoms.
during that.
So I wouldn't expect it to be related, but
Okay.
A lot of patients on the website, though, do say that they have memory loss for a little period of time, and then gradually it starts coming back. I know that I did, but
I can speak to that a little bit. I'm a professional counselor, and stress, if you're under excessive
Mm.
stress, you will have
That's what I was
things you will fight. Just
yeah, that's again what I was about to
creates brain fog.
mention a similar point too, that
Trauma creates brain fog.
Yeah.
So I
I
have
was
a lot
definitely
of,
under
I have a lot of stress, and I have a lot of brain fog.
I have heard patients ask if there's any relation with feeling fatigued around when they get radiation. What I tell them is essentially what you're saying is it's a lot of change and stress and a lot of appointments and treatments and things in a short order of time. And so that alone can certainly lead to fatigue and, potentially things being a little foggy. And so I agree with you. I think that probably has a great deal to do with it too.
So I have 2 questions for you. One, do you ever, this is kind of from a professional standpoint, do you ever encourage your clients to have some type of counseling or mental health?
Every patient who walks in the door. So we actually do suggest a psycho-oncology consult for every patient we see in my clinic. So a psycho-oncologist is a health psychologist. So we work with Dr. Cohen at our hospital. Basically, they are health psychologists who specialize in speaking with patients who have a new cancer diagnosis. And Dr. Cohen, for example, deals exclusively with patients who have eye tumors. And what I explain to all the patients is, because when they hear that term, some people can be a little bit put off. So I say, it's not a psychiatrist. A psychiatrist is a doctor who looks after patients who have a mental illness or are mentally unwell. A health psychologist like Dr. Cohen looks after perfectly normal individuals who are going through an enormous amount of stress with a new cancer diagnosis. And so we do actually offer it to all of our patients.
So my second question is, I had a diagnosed in July, last July, had the surgery August 4th and 10th in Dallas with Dr. Timothy Bowler, and had my 3-month follow-up 2 weeks ago, and my vision has regressed. It was 20/60 at the time of diagnosis, now it's 20/80. He says because there's swelling of the cornea. So I have stuff I'm supposed to be doing to the eye for that. But is that something that's common? Are there side effects that I should be concerned about that could result from swelling of the cornea?
It's a good question. Some people have a predisposition to have swelling of the cornea to begin with. So there's a condition called Fuchs dystrophy. There's a variety of reasons why the cornea can be swollen. And it's possible that in your situation, just having had radiation kind of pushed it over the edge. That being said, actually there are a variety of interventions for corneal swelling that can be very effective. And so I would say, I'm glad to hear that your vision hasn't fluctuated a whole lot. And there's always some change. It's unusual for people's vision to be completely unchanged in the immediate period where you're kind of healing up. So what I would say is it sounds completely in line with kind of normal healing from having had radiation. And if it persists, you may want to have you see a cornea specialist, and there are a number of interventions that they can provide to prevent that from progressing.
If I normally had dry eyes anyway, would that make me be predisposed to have cornea swelling? My eyes have always been very dry.
I think it depends. If it's surface irritation, yes, for sure. If it's actual corneal swelling, which might indicate a problem with the corneal layer being able to pump out fluid and keep it clear, that could be a different issue, actually. So it may be worth your while to see a cornea doctor, a cornea specialist. I know there's many excellent ones in your area too. I know there's many excellent ones in your area. My current fellow actually trained out there for.
Okay. There's probably one in Texas Retina Associates, because we got everybody there. So. Okay, thank you.
Are there any neurological issues from radiation. I'm 19 months post-radiation, and just recently it's just kind of been, I can just draw a line around part of my, it's just sore, just feels completely different than the other. I don't know if there's any like other type of nerve damage or effects that the radiation could. Does ever a neurologist come in to the mix of the medical team?
It's a good question. So there are neuro-ophthalmologists who sometimes we consult if there's a problem with the optic nerve, the cable between the eye and the brain. And that can happen, you know, if you're giving radiation to a tumor that's right next to the optic nerve, unfortunately the nerve will suffer damage from that. But that wouldn't be expected to cause the symptoms that you're describing. That would just cause vision loss. So if you're having any different sensation in your face, things like that, that also wouldn't be expected to come from the surgery to put a plaque in or the surgery to take the plaque out, to be honest with you. However, what I do notice among patients in general is, having had any form of radiation, you know, there's a period of time when things are still a little bit sensitive and are calming down, and people tend to be more aware of that side of the face and around that eye. Typically, I would say after a few months, though, things tend to settle out and people become less aware and have less of those kind of symptoms. So, but I would say if you're still having any kind of pain symptom, discomfort, anything like that, let your doctor know. It's not a bad idea to consult seeing a neurologist, because it may not even be related, to be honest. But if it's all kind of localized to that side, it could just be kind of normal healing that's occurring from having had the plaque.
If you have a plaque on the macula, I had a plaque on the macula region. What are the long-term for visual have you noticed with your patients?
It's an excellent question. I actually tend to use Proton more if it's in the macula, just because you can give a little bit of a tighter margin sometimes, although I've used Plaque for that too. In general, the closer you are to the macula or the center of the retina or the fovea, the risk for vision loss long-term is definitely higher. The reason is just because those areas are getting radiated. And so, you know, the effects to vision, usually, you know, it's most profound after about a couple of years. And I actually do have patients, there was one of them whose photo I showed in the slide in my talk earlier, who had a tumor actually right around his nerve. And it defies all rhyme or reason, but he's like 11, 12 years out and his vision is still quite good in that eye. So what's interesting, and this is actually an area that I'm studying in my research, is we have general kind of estimates for how people's vision will end up, and we kind of extrapolate based on, again, how thick the tumor is and how close it is to those critical structures for vision. But sometimes we're surprised as doctors too. We see patients, we say, wow, you're doing better than I would have thought, honestly. And I'm curious to try and understand why. So we're looking at a bunch of different parameters in terms of tumor size, location, the type of radiation, and so hopefully we'll have a better answer for you. My goal is to be able to create a prognostic tool where we can actually be able to input a patient's visual acuity at the start, the size of their tumor, the treatment they're getting, and then to be able to predict where their vision will end up. It's something that we hope to do. We have access to a database of over 4,000 patients that actually one of my colleagues have been treating abroad. So I think that's something that we'll have available at some point, hopefully in the near future. But so the short answer to your question is, if the macula was receiving radiation, the chance of losing vision long term is pretty high. Now, how much you lose is a bit of an X factor, because there can be definitely some variability in that. I have some patients who had radiation in their macula but still have quite good vision, and others who have suffered some vision loss. So some of it's individual.
So is it almost a guarantee if you had the radiation, you're going to develop a cataract?
That's a really good question. So the lens sits in the middle of the eye. So the closer your tumor is towards the front of the eye, the higher the chance that your cataract will be accelerated. So if it's iris ciliary body, your cataract would be expected to progress more quickly.
It was choroidal, but it was kind of, I had a really small tumor. Dr. McCown goes, how did you get here this fast with that small tumor?
Yeah, that's great. In general, a couple things. So first off, in the age group of patients who get this problem to begin with, many already have some degree of cataract as it is.
I had some.
Yeah. I believe Dr. McCannell will often combine her plaque with a cataract surgery and with oil too.
Yeah. So, yeah, it's still there.
Oh, you still have a cataract? Okay.
I still have a cataract. I just have my eyes examined and the cataract's still there, so. But I thought she had done the cataract surgery and a retinal repair at the same time. So, but when the doctor examined me, it says, well, you still have your cataract, it's still there, it hasn't changed.
Got it.
So,
That's great. It can always be removed later.
so, but my vision is still 20/20, but I just had my plaque in February, so.
Well, some of it depends also where it is in the eye. So if your tumor wasn't near the optic nerve,
It
or
wasn't near the optic
was-
nerve, it was like kind of, I know it was way back, and just by judging when they had to do
Mine was just like that.
where they put the little thing on your eyeballs, the ultrasound, thank you. And I having to look way back, he goes, oh, yours is way back in the back of your eyes, so, but it wasn't close to the optic nerve.
Yeah. Well, I hope your vision remains excellent. Yeah. It sounds like it will.
Right.
Is there a Lincoln protocol for the Avastin?
That's a really good question. So unfortunately, there's no good study to guide people. So what people end up doing is we treat it as we do other conditions. So what we do know is that Avastin medicine only tends to last in the eye for about a month. That's the reason why we see patients back every month. And we tend to, as a general rule, inject every month until the problem goes away. So some of that's dictated by what we see and how the patient's responding. So there is no kind of set number. What I'll often tell patients is if there's a good amount of fluid to begin with, I'll tell them realistically you'll probably need at least a few for us to see how you do with it, just so they're not just expecting one and done. But there can be some variability for sure in how many injections people need.
Any long-term worries if you have month after month after month of the shunts?
Of the injections?
Yeah.
Honestly, no. And the reason we can say that is we've been using these injections for well over a decade, almost 15 years, for macular degeneration. And there are indeed some patients who get injections every month for 10 years or more. And from what we've seen, not much concern. There's a rare risk of an infection, it's like 1 in 2,000, but if the procedure's done properly, that risk is pretty low. What's that?
We're rare people, though.
It's true. It's a good point. It's a good point.
Or they are.
We're still here, so.
Is there not a drop that's developed that you wouldn't have to do the shots?
It's a really good question. So unfortunately, no. Some of it has to do with penetration of the medicine into the eye. Now what they are doing, and this is a big frustration for people who have diabetic eye disease or macular degeneration, and they're getting these injections every month for a very long time. There is a push towards medications that will last longer. So there's like a depot device that's coming out where it can be refilled every 6 months. So there are things in the horizon. But unfortunately, no. You can try like steroid eye drops, but usually if the swelling in the retina is severe, it's not going to really do enough.
Because I did the steroid drops after I had that irritation and, the flashes, and it completely went away. So I didn't know why, are some people symptoms appeased by just steroid drops?
For sure, but steroids tend to help symptoms that are on just the surface of the eye.
Okay.
Now, if there's fluid leaking from your tumor in the back of the eye or radiation damage, things like that, for those conditions, it often needs the medicine to be delivered kind of right inside the eye, so the medicine can work back there.
Okay.
Great, excellent questions. Anything else?
The genetic test that you were talking about, not the Castle one, but the other one, would that be the same test that they do at UCLA?
It's a good question. I believe Dr. McCannell does MLPA, which is another excellent test as well. It's not quite the same test, though, as far as I know. But really, all these tests are looking for the same information. So they're assessing a number of critical chromosomes, like chromosome 3, for example, and 6 and 8. And they're looking for critical mutations. So. Great. Well, once again, thanks everybody for your time.
Thank you.
Appreciate speaking to you.